So we make sure we record this and have this for everyone. So welcome everyone and thank you for joining us. I think we have a great webinar today talking about COVID-19 and the impact on health and nutrition in Ohio's children. We want to give a big thanks to our presenters who they will introduce themselves to you as they present today for all the work they put into the webinar and for sharing their expertise with us. We also want to give a big thank you to CareSource, who's sponsoring our webinar today. And they have sponsored this entire webinar series, and we really appreciate that. They did not influence the content of the webinar at all, but have just been great partners in bringing education and resources. And just to briefly review our agenda, and I'll try to keep us on a time track. I think we're going to have plenty of time. Dr. Bowling is going to do an overview today, and then Dr. Murray and Bridget Hobson will talk about food insecurity and healthy lifestyles in high-risk communities. And then Dr. Levitt will round it out with healthy routines and active lifestyles, and then we'll have a brief wrap up at the end. And I'll continue to put some information in the chat box too as we go through today's presentation. So with that, I am going to throw it to Dr. Bowling and he can introduce himself and we'll get started.
Thank you so much. It's great to see you guys today, even here just virtually. My name is Chris Bowling, and I am a pediatrician at Pediatric Associates in Greater Cincinnati. So, what's this Kentuckian doing on an Ohio AAP call? I live in Ohio, practice in Kentucky, and cross that river all the time. So, and I'm active in both chapters. But I am first and foremost a general pediatrician. So there we go. Not wanting to advance there. So I have no relationships to disclose and not discussing any off-label uses of things. So our oh,
and Dr. Bowling, I will advance the slides for you. So just say next slide when you want it to move.
Next slide, please. So our objectives here, just to take a broad 30,000 look view over COVID and what the COVID pandemic has done with our kids from a healthy lifestyle perspective. And we know it's been a lot, but I think we've got some really interesting things to show you. We're also going to talk about some advances that we've had. And what I'm going to try to do here is to set things up for some techniques maybe that will help in carrying through some of the things that Bob and Michelle are going to be talking about. So next slide. So let's take a little journey back in time. If those of you can remember before the pandemic, and even back further than that, back to the, I guess maybe it was the Pleistocene age here before everything has started. But let's take a look at our next slide here, and we can talk about where we were looking about the obesity epidemic. It seems like that was a long time ago. Well, it hasn't gone anywhere. And if we go back a few decades, back to 1990, so when we started noticing really that there was a trend, an increase in obesity rates in adults. The map up to the upper left-hand corner into the 1990 map was when we really first started, like I say, noticing that more than 5% of the population was above the 95th percentile when it came to BMI. And that was having a BMI of over 30. So people go like, okay, so what's this more than 5% over the 95th percentile? Isn't that the definition of 95th percentile? So remember, these rates were frozen in according to 1975, 1980 numbers. They had been static for a while, and then we started noticing this trend upward in those few decades. And it started advancing very rapidly. You can see like the prevalence of obesity jumping dramatically for every 10-year period. And this has really continued on into 2020. And I'm going to show you some slides that address the pediatric population that are really pretty shocking. By a lot of measures, everything that happened from 1990 up to 2020 has doubled since 2020. Kind of shocking. So everything that happened over these 30 years that we're looking at, that represented by this slide, really, and this is just 20 of those years, we've almost, by a lot of measures, lost as much ground over the course of the pandemic as we did in these first 30 years. So next slide. So we've had a decade of challenges since that last slide that I put up there of 2010. We had our 15 minutes of fame. People were like, okay, yeah, we've heard about pediatric obesity. Now let's move on. What's the next topic? There have been lack of effective programs, as we know. We didn't have a lot of data out there. There's been weight bias and weight stigma that were very prevalent, but I think we're making some progress in this area. And then we had a pandemic. It was been especially hard on people who already had challenges with obesity. Rates increased in all age groups, but there were some groups that were really particularly hard hit. And what were those age groups that was prevalent, were hit by prevalence and severity? It was the very young and those already with obesity. So unfortunately, some really vulnerable populations. And so our young kids are the ones who really have been suffering most, and those kids who already had obesity. COVID in patients with obesity, we know, is sort of a puzzle still. We all know that fatty tissue, adipose cells, are not just warehouses of energy. We've known for a number of years, because of the effect on the liver and other parts of the body, they are inflammatory cells, and they are really profoundly affected by COVID. There's something special that happens with fat cells in a COVID infection, and it's not good. Next slide. So let's take a second to look at these slides. And so let's look at them each a little bit in depth. I want to get you oriented to each one of them. So the slide, the graph in the upper left-hand corner. So these really come to courtesy of the amazing staff at the Division of Nutrition, Physical Activity, and Obesity at CDC. They're awesome. And there's a lot of Ohioans and Kentuckians on that group. Matt Ritchie, who is a physical therapist from Cincinnati, is part of this group. And it's just an amazing group. And this comes from some of their data that was published in Morbidity and Mortality Weekly Report. Can't talk right now. So let's take a look at each of these graphs. So the first graph in the upper left-hand corner is kids ages 3 to 5. The one to the right of that is ages 6 to 11. 12 to 17 is lower left-hand corner, and then young adults, 18 to 20, is lower right-hand corner. And this really demonstrates the biggest impact being on our kids who are youngest and our kids who already had obesity. So each of the types of lines, like the solid blue line on all of these, represents kids who already have severe obesity. The line with dashes in it, those are kids with moderate obesity. The dotted line is kids who have overweight. Normal weight kids are the alternating dash and dot line. And then the bottom line there is kids who are underweight. So if you notice the inflection point where it says the start of the COVID pandemic period, take a look at the slopes on these lines. What happened once the COVID epidemic started, the pandemic commenced. And what we see is really the steepest slopes affecting those kids in the 3 to 5 year range, and the steepest slopes being those kids who already had severe obesity. And this is the source of my commentary of saying that, like, the last 2 years have been as bad as the preceding 30. That's shocking, I think. Next slide. Now let's take a look at some graphs, and we're going to do these a little bit differently. Now we're going from left to right, outcomes of patients with COVID. And these outcomes are what? So the first two on the left are hospitalization rates. The next two are ICU admission rates. The next two are IMV, or mechanical ventilation. And the last one on the right is death rates. So the top curves, the ones that have the black curves on them, are collapsed. Those are all weight classifications. The bottom curves are the various classifications that we were using before on age, but now we're looking at adults, okay? So now this is adult data, and we're looking at their outcomes. And what we'll notice is that all patients that once you get past people who are severely underweight, so once you get to those normal BMI ranges, all these outcomes, I'd encourage you to look mostly at the top charts on these. All these outcomes get worse with increasing BMI. So this sort of, is a little bit of circumstantial evidence that fatty tissue presents a special problem for patients who have COVID. They have all these worse outcomes. Okay, next slide. So now that we're all completely bummed out, next slide, it's time to look up. We've got other things that are happening. So I will tell you that we've made a lot of progress since the preceding decade, the decade leading into the pandemic, and actually through the pandemic. What's changed? We have a better understanding of obesity, and why is that? You can hit the advance button there. We now recognize obesity as a disease, and it's a chronic disease, which means that it gives us as providers a better handle on the approach. This is not something that you start a diet for and then you fix it and you move on. It's not an ear infection. This is a chronic disease that requires a lot of different treatment modalities. And it takes us, I think, away from blaming and shaming. We do not blame our patients for having ADHD. We do not shame them for having asthma. Are there modifiable things in the environment that affect those disease processes? Of course, just like obesity, but it is not their fault. And I think we need to really get away from that. And I think, honestly, we have gotten away from that. A lot of our colleagues are not quite there yet, but we need to lead the way for them. Next slide. We really, this is a big part of being successful moving forward. We really need to remove and reverse weight bias and weight stigma, which can be defined as negative attitudes towards beliefs and negative attitudes and beliefs or towards others because of their weight. These are pictures actually from the Rudd Center at the University of Connecticut. And these actually, rather than showing people with weight issues, sitting around eating bad food, these are showing people who are trying to engaging in active, healthy lifestyles. Next slide. We've also made some real progress in feeding practice. There are 3 studies that are listed here. The Insight study. I also we're going to give a shout out to the Institute for Healthy Childhood Weight at the American Academy of Pediatrics and the Ellen Satter Institute for kind of pushing these things. But when we talk about progress in feeding practice, next slide, we're talking about there's really good data that we need to be following responsive feeding with our kids. And we're going to get into a lot more of this as our webinar moves on. And this is a lot of our patients who suffer from other challenges. There are things that we need to do to really promote responsive feeding, which we know from data now really makes a difference when it comes to staying at a healthy weight. Next slide. What makes it hard for parents to hear our advice about nutrition? And I want you to keep these in mind, especially as you get into Dr. Levitt's talk. She's got some great advice in there. And I think getting the message across to families, there are certain things that we need to be aware of that we want to try to avoid, and things that we really want to try to punch to make that message that Dr. Levitt's going to give you toward the end here really stick with them. Number 1, really be careful of the use of the word obesity. Parents don't like it. I actually did a focus group years and years ago with patients in my own practice. We got it published, and parents at that time, back in the early 90s, or in the early 2000s, were saying that, you can use obesity, just define it for me. I think it's gotten too supercharged. And so really trying to avoid obesity language, especially as related to infants. We want to be careful of guiding too much on future outcomes. I mean, that sounds a little counterintuitive, and that's what we do as providers because we're worried about diabetes and other things. But we really want to try to avoid being too focused on future outcomes. It also hurts if we have limited knowledge of the recommendations. We want to be knowledgeable. I mean, that seems basic, but parents are going to ask back, and you really want to be armed with the right information on it. It also doesn't help if there's a disconnect between what you're guiding them in and what their personal experience is. So what makes it easier for them? Respect their expertise. Saying like, we really want to be able to say to them, I understand where you're coming from, and maybe you can use this piece of what you told me, and maybe we can kind of add or adjust it. You want to give the why, but don't go overboard. You want to give the why behind the recommendations, why things make sense, why we're recommending what we're recommending. But again, you don't want to get too far into the weeds with families. You want actionable strategies. Parents want, like, tell me, specifically what you're asking me to do. What's the real meat of the issue here? So being very actionable, like we would with any sort of SMART goal. You want something that is doable. And they also want it tailored. You know what? I think that's one of the things that we learn with weight. Those of us who do a lot of weight management, there's a lot of different nutrition plans out there. The one that's going to work for you is the one that you can follow. And that goes with a lot of things. So with that, I didn't know if there were any questions there before I pass it on. Great question about responsive feeding. There's a lot more out there on responsive feeding. We do webinars on that a lot from the American Academy of Pediatrics. And it's a whole area that it's a part of responsive parenting. And it's a really important piece of parenting. And it's a fun comment. So great question from Christina. Can you elaborate on not calling an obese kid or infant obese? So I would like to do two things there. Number one, we actually get away from using the word obese and overweight as an adjective. I don't know if I slipped up in my presentation today, but we really want to talk about kids as having obesity or having overweight. We don't talk about kids being an asthmatic kid or a diabetic kid or a hypertensive patient in room 4. It doesn't define them. It's a chronic disease. So the first thing is what we want to do is we want to try to be mindful of using person-first language with our patients. Our patients have obesity. It's a chronic disease. So we want to use it. When we use it, we want to use it that way. And then we also, it's great. This is such a great question, Christina. But then the other piece of it is we want to keep the emphasis on positive things. It's fine to use the term and is defining a condition. And I will tell you, my patients who have severe obesity, we talk about obesity as a chronic disease, but we don't allow it to define them. We don't allow it to describe them, honestly. It's a condition that they have, and we want to speak to it that way. So, we don't say, so you as an asthmatic want to do blah, blah, blah. So it's the same sort of principle. We use the term, we use it very carefully, but we don't use it to conjure fear. I hope that makes sense. There's great stuff. Like I said, if you ever go to the RUD Center, it's RUDD Center at the University of Connecticut, they have exhaustive and fantastic stuff, including those pictures that are public domain use if you're looking for positive images around patients who have obesity, have weight issues.
Yes, and I'll try to, or
I'll type that link in right now.
Yeah, that'd be great. You can put that in the chat. Thank you. I think that's so helpful. And what you were talking about with the language just creates such a mind shift too. So thank you so much for that. If there are any other questions, we do have just a minute or so before we want to move on to Dr. Murray and Bridget. So again, if you want to type any additional questions, Dr. Bowling is going to continue looking at the chat box too to chime in on questions. So thank you again for all that wonderful information. And with that, we will throw it over to Dr. Murray and Bridget. They can each do a brief introduction, and then Dr. Murray will take over the reins.
Thanks, Kirsten. I'm Bob Murray. I also work with the Ohio chapter of the American Academy of Pediatrics. In my clinical life, I was a pediatric gastroenterologist with a focus on nutrition. So I've been very interested in how COVID affects the child in terms of their nutrition and therefore their health and well-being. Next slide. I don't have any disclosures in terms of this particular talk. just some learning objectives, and you'll get the slides so you can review these. Next slide. The interesting thing about COVID is how disruptive it was, not just for us as adults in our work life and, the hassles and getting to go out with our friends and other things, but also in terms of family life and children. Children's lives got nuked by this disease. And it really took away from them the structure and the platform that supported their health and mental health. And as a result of that, they have had dramatic changes for the worse in terms of not just their nutrition and their education and academics, but also in terms of their sense of support, their relationship with adults that they were used to seeing every day, the bus driver, the lunch lady, their teacher, and their ability to express themselves. So we see a lot of health problems, but also a lot of mental health problems that are being manifest because of COVID. And it goes all the way from young children all the way up through adolescence. It's been very devastating on all of us, but particularly on children. Next slide. A crisis is unpredictable. And what happens to most Americans is that they're going along and they have balance, and something happens to unbalance their ability to keep up in life with their costs and their budgets and other things. So you can think about it, a family that's very close to the poverty line, if their car breaks down, it simply ripples across. They don't have money for rent and light and heat and food, and it can be a severe stress on that family. We know from the recession that we all went through in 2007, 8, 9, 10, that happened to people who were not living close to the poverty line. They seemed to be stable. And then when that housing bubble exploded, everything went bad for people who are not used to being considered at risk. Since the Great Depression, America has built a tremendous network of programs as a safety net to put under families in the US. And as a result, when we had our recession, we didn't see soup lines. We didn't see families living out of cars. We didn't see all the problems that they saw back in the 30s. We continue to build that safety net program and revise it and make it responsive. And this safety net is one of the reasons that we've done well with the recession and now with COVID, because these programs exist for us. Next slide. So anytime you come across a family as you're working and they're suddenly finding themselves in trouble, I would urge you to begin to tap into resources. And one of the resources we have is 211.org. They will take calls, emergency calls from you about families or children in crisis. And they have a number of different ways of steering the family to resources that can help them stabilize that crisis. So this is a simple little emergency phone resource. They in turn have a lot of access to things to offer the families. Next slide. Chris talked about overweight, and actually there are 3 kinds of malnutrition, all 3 of which occur in every country of the world. We're used to talking here in the US about overweight and obesity because it's become so commonplace for our children and all of us as adults. But along with that, we still have underweight in terms of severe muscle mass and tissue growth, severe restriction on that, even linear height, so-called stunting. We still have those present in America, and it's a component of food insecurity, poverty, hunger, and other things that lead to that. The third kind of malnutrition, so you have overweight, you have underweight, and now you also have what's been called hidden hunger, and these are micronutrient deficiencies like vitamin D deficiency, vitamin A deficiency, iron deficiency, which is devastating for children in particular. Those are very difficult to find and identify, and all three of them, overweight, underweight, and hidden hunger micronutrient problems, are the result of poor diet quality. So one of the pieces of our safety net program, and one of the most powerful pieces, is our nutrition safety net, meant to go at these families where food security is something that they constantly face because of changing circumstances in their lives. This group of people are at the highest risk for food insecurity and micronutrient deficiencies. And it's not a weight issue. It's not just whether they are underweight or overweight. Both of them are elements of malnutrition. And this is the group that has a tendency to fall into that category. Among the highest is always children. Next slide. As Chris mentioned, we had a problem with obesity. I'm going to show you a map on food insecurity in Ohio and the US before we got into COVID. And, it took years, but we came out of the recessions, the recession from 2007 to 2010 and it took years for us to get back our footing. And then by 2019, we were back to kind of where we were previously before the recession. But you can see Ohio, Kentucky, West Virginia has a particular problem with food insecurity. Across the country, it's about 1 in 4 children live in food insecure homes. In many areas in rural, southeastern, and urban Ohio, that is much higher, particularly now, much higher than 1 in 4 or even 1 in 3 children. Next slide. So we're moving along and we've got this problem with children with food insecurity, living in homes with food insecurity, and then COVID hit. And you can see what it did. The first thing it did is cause a surge, really a tsunami of unemployment as we isolated all these restaurants, hotels, travel, everything started to constrict down to the bare basic needs of life. And as a result of that, families were thrown into insecurity, poverty, difficulties with rent, problems with handling their budget. Next slide. Well, that had an enormous effect on food insecurity. When you look at the line here on these little bar graphs on the bottom, the one on the left is mothers with children 12 and under facing food insecurity. They didn't have enough to make it through the month. You can see that line is 2018, and look how far up that went after COVID hit. And you can see the same question, slightly different question asked. The food we bought didn't last, and we didn't have enough money to get more. Tremendous increases from 2018 because of this uncertainty around employment, finances, and in our daily lives. Next slide. This is our safety net program, and it is a phenomenon. As I mentioned, we went through a recession that would have been devastating, except we had these safety net programs, and they held and they did their work and kept Americans out of deep, deep trouble. It's built on a number of programs, starting even in pregnancy, going all the way through childhood with the WIC program, daycare programs, school programs, programs for people that are having emergency problems, senior programs, all the way through life. The US has these programs available to support the family, particularly the families that are on the border of being stable versus unstable. Next slide. It's important to realize that for children and teens, food insecurity is a huge stress. So kids, even before COVID, were under immense stress when they were facing food insecurity. It affects their ability to function. They simply have difficulty with learning. They have difficulty with health and mental health problems. And it becomes very clear in adolescents, particularly, they become depressed, suicidal, they feel alienated from their environment, they're embarrassed and humiliated by food insecurity, and it really is a problem. So when COVID hit and food insecurity went through the roof, many, many more kids were pulled in, and we're seeing those statistics. Suicidality, depression, a sense of loss of purpose, lack of attention, inability to learn, all these things are worsened now that they're in COVID, and so many kids are in this insecure world. Next slide. So when you're working with clients and you're communicating with people, there are two very simple questions you can ask. And this brings out almost 100% of food insecure families. If you ask them, the answer is yes to either question. That's a family that's highly likely to be facing food insecurity, and they need your help to steer them to resources that can stabilize their situation. We've been working with physicians, dietitians, social workers, and also with peer educators and for home visitors to really ask these questions. The family will not volunteer this. It's something you really have to draw from them, because a lot of times they're embarrassed and they're feeling at a loss for what to do. So you need to be the one to ask the question and find them. Next slide. The first thing you do is you find food if they're in crisis now. So if it's the end of the month, their benefits aren't going to make it to the end of the month, they don't have more money, that's a family that needs to be steered to a local food pantry, most of which are neighborhood-based churches, and they're all around in different places you can go, and there will be food pantries. If you don't know where the food pantries are in the client's neighborhood, you can go to the food bank and it will give you a listing of food pantries available to you in your local area. It can be urban, it can be rural. They're all over the state. Our food bank system in Ohio is spectacular. And when the crisis came for all these families from COVID, the food bank system and their food pantries that are affiliated, all of them stepped up. It was a massive effort on their part to keep people from being hungry. And that was very, very important. Next slide. The second thing I always urge families and their caregivers to do is help the family get into the SNAP program if they're food insecure. This is a tremendous program. It serves 45 million people in the US per month. It really keeps people from having to spend so much of their budget on food, and it frees it up for other things to stabilize their transportation, their housing, and their electricity and other things. So this is a very powerful and important component of our safety net. Over half of the people in SNAP are children and seniors. These are really vulnerable, the most vulnerable people. You can see here, I hear people say all the time, you know, oh, they're living on SNAP. Nobody's living on SNAP. It is a supplemental program, but it can make a big difference in just keeping the family's nose above the waterline. It's only about $4.21 per person per day, so it really just covers meals in a supplemental way, but it can make a big, big difference. One of the things I want to tell you about, and this is something that doesn't get a lot of publicity, but there is a SNAP education component that really teaches these families about budgeting, shopping in a very economical way, putting together foods that make the diet stable for the least amount of money. This is a great program. It's part of the SNAP program. Steer your families towards SNAP Ed. Next slide. The second question I always ask families is there a possibility they're eligible for WIC? The Women, Infants, and Children's program, the WIC program, covers pregnant females from conception all the way through breastfeeding, and covers the newborn infant from that pregnancy all the way out to age 5. Again, giving nutrition and support to the family and the pregnant female to ensure that their diet is high quality. So SNAP really provides the calories for the family, but WIC really targets the pregnant female and the newborn child and the child out to age 5 for diet quality. They really look to keep iron and zinc and all the vitamins and everything's provided there. And I'll tell you one fun fact. We have not done well with controlling obesity, as Chris mentioned, but the WIC program has consistently, in this decade, since about 2013 or 14, they have shown an improvement in obesity among their client children consistently over the last several years. So they are bringing obesity rates down by prevention and by ensuring diet quality is really high. It's a tremendous program. Next slide. For kids in preschool, which of course was disrupted during COVID, but if they're in preschool, it takes many different forms. It's not all, a center, a childcare center. Most of preschool or child home care is done in a person's home, and it's kind of a private small business, essentially. This program was designed to help all those kind of businesses to get meal vouchers that reimburses them for providing food to their client children. So if you know or you come across a person who is organizing this kind of neighborhood childcare thing as their own business, you can really, really help them by getting them in this program, because it will reimburse them for the money that they spend on nutrition, and they'll educate them to provide a higher quality of nutrition for these very young children. There are ways of getting at this from a federal level, but I would encourage anyone in Ohio, if you come across any client that is starting to organize a childcare environment, get a hold of Children's Hunger Alliance. Their job is to make it easy to get through all the paperwork and get those resources to those family and those caregivers that are providing childcare. Really, really excellent program. Next slide. Here's where we got in trouble this time. We didn't lose school in the recession. Kids maintained the stability and the organization around school. And school is probably our most important nutrition program in the country for children. It is a day-to-day provider of school breakfast, school lunch, after school meals, and summer meals that keeps kids who are otherwise food insecure out of food insecurity and gives them a much better diet quality than they would get otherwise. As you can see here, it serves 55 million students. It is something that improves their diet quality, but also improves their school performance, their sense of attention, and their sense of personal sense of well-being, and it lowers stress. These are really important. So this is a school breakfast or school lunch program. Next slide.
Dr. Murray, I just wanted to mention we had a comment in the chat box.
I'm sorry.
Just around the school breakfast and lunch that, there's some anecdotes out there about some of the food may not be the best choices. Pop-Tarts for breakfast. I know there was a recent photo on social media sort of circulating with the school lunch that wasn't the best looking. So do you have any comments or thoughts about lunches that are provided in schools, or if there's a concern about that, kind of what to do?
No, it's quite the opposite. If you look, we've got good data on the diet quality being provided by the schools in school breakfast and school lunch. And if you go all the way back to the 1990s, when the obesity epidemic started, one of the questions was, oh my gosh, is school contributing to it? The studies clearly showed that they do not contribute to it. In fact, consumption of school breakfast is associated with a lower risk of obesity rather than higher. But the thing that started in the school food service in the 90s was to investigate the quality of the meals relative to the dietary guideline recommendations. And so more and more they have matched those. And in 2010, they really set out to make sure that the school meals provide the kind of nutrition that's recommended by the dietary guidelines for Americans. How do we know it's working? Well, there is a healthy eating index, so-called HEI, that is created from the dietary guidelines. And if your eating and my eating matches up with those recommendations, the score gets higher. When I look at school meals, they have taken kids from a score of 40 out of 100 points, pretty miserable, and pulled them up now approaching 60 out of 100 points. A lot of the problems for that other 40 points come from snack foods, foods consumed after school and at home. But the school meals, if you look at them individually, separate from the rest of the child's eating, those meals are running close to 70 points or higher at breakfast and lunch. So they really are giving kids a platform. Now you see Pop-Tarts and you think of that in terms of, it's not a good food, or, it's the wrong kind of thing. But the school food service balances that with other things so that the child is getting whole grains, fruits, dairy, fruits, vegetables, and proteins all mixed throughout the week. So you can look at one picture and say, I don't like that, or that's not a good high quality food, but it is surrounded by other foods that make the quality higher. The more you know about school food service, the more you'll realize that those people are doing an astonishing job all the time. But after COVID, they really had to step up and be creative to figure out how to get that food to kids. And I have undying admiration for them doing that on a budget that would be impossible for us to give high quality food to families if we had to do it at home. Very tough thing, but I can show you. I'd be happy to sit down and just give you way more information than you want about school meals and what school food service does. So I'm a big defender of them after looking for 25 years now at what they have to do to make their meals work.
All right, thank you. That was very helpful.
Next slide. So half the kids in the country qualify for free and reduced price meals. And what's interesting is that's the exact same number that qualify to be in WIC. We think of ourselves as a wealthy country. We're not wealthy on the individual level. The disparity is spectacular. And the people, the majority of people in this country are on the lower end of the financial spectrum. And that's who these safety net programs are built for. Next slide. We've always had a big problem in terms of food insecurity with summer. You can imagine you're a food insecure child. You're getting school breakfast and lunch, maybe after school meals, and now you're out for 3 months of the year. That is like walking into the desert. They don't know where their next meal is going to be. So the USDA built summer meal program. They tried to strip away as much regulation as they could in order to ensure that these meals were getting to kids, but only about 10 to 15% of the kids who are eligible for free and reduced price meals at school breakfast and lunch get them in the summertime. So one of the things that the Department of Education here in Ohio has worked on for a decade now is to find ways to get these programs, these meal programs in the summer into the neighborhoods where the kids are and live. So you'll see them in rec centers, churches, clinics, you see them libraries, you see them all over the place trying to reach kids. This experience from this is what really gave us a break in 2020. When the schools closed, then the Ohio Department of Education and all the other providers started to shift over to this summer meal mentality. Regulations by the DeWine administration were stripped away to the minimum to make sure we could do that. And one of the organizations I mentioned to you, Children's Hunger Alliance, supplied 10 million meals in the next year to try and make up for the fact that schools were closed. It was just a yeoman's effort and very, very difficult. So this has been one of the important programs. We need to keep growing it. Next slide. The last thing I'm going to say is, okay, so you find a family, you realize they're at risk, you help them get their resources, and then, counsel them and give them a heads up as to how to think about nutrition. I think about nutrition in very simple terms. Every meal, every snack, I'm looking at 5 food groups: fruits, vegetables, whole grains, dairy, and quality proteins. And I try and get families at every meal and snack to mix and match those so that they get as much diversity as they can, but also the highest quality of food in each of those food groups that the child likes and will eat. Next slide. So a quality diet you hear people talk about this all the time, but I want to just give you one piece of advice. Every person has their own personal dietary pattern that they eat, and they're the foods that they've grown up with, they like, they prefer, and they tend to eat that pattern over and over and over again. You will not get them to throw that away and take up a new diet. People don't work that way. But you can get them to make little substitutions and swap one thing for another. Maybe they eat lettuce on their turkey sandwich, and you can convince them to do lettuce that now has a blend of spinach and other lettuces that raise the quality just a little bit. That's really what you want to do, is help them understand that they can make changes, but they don't have to throw everything out that the child really likes and prefers. Next slide. We know if you can get diet quality up higher and that dietary score, that healthy eating index score rises, that it improves health over the lifetime of the person. So when I think about those HEI scores going from the 40s in the 90s to almost 60 now, that's a tremendous improvement in quality. We need to keep going, but what a great advancement we've made in the last 30, 40 years. Next slide. The last thing I'm going to tell you is one of the main things COVID did that's causing trouble for children and teens is it ruined the structure of their day. You figure they used to sleep, get up, eat, go to school. They had their day structured. Suddenly they're thrown into the summer-like environment, and they didn't know how to adapt to that. And as a result, whether they are overweight or underweight, their diet quality suffered greatly. They didn't sleep well. They're getting mental health problems. We need to help families think about, how do I structure the child's day? And they start by ensuring every child gets enough sleep. That's the most important thing. Sleep alone is one of the steps, as Chris Bowling will tell you, that works against the likelihood of becoming obese. Quality sleep, make sure that that's adequate, and then build the day around that. That's the best advice you can give a family that's looking at the ups and downs of COVID. Last slide. And the last thing I'll say is kids are doing more screens, they're staying indoor more, they're not getting to play. And that was a component piece of going to school and hanging with their friends. This is something that we have to actively get kids out playing, and we need to remind the parents they need to play too. Recess is good for all of us. Make sure that there's active play during the day and breaks in the day. That's part of the structure that makes childhood. Next slide. And this is the last slide I'll say. Is the family in trouble? Ask the questions you have to ask. If you find that you feel they are in trouble, offer them resources, beginning with immediate resources and then longer term support. And then finally, offer your advice about the diet, sleep, and daily structure. It's the best thing you can give a family that seems to be having trouble. Thank you so much.
Thank you so much, Dr. Murray. And Bridget, are you with us?
Yes, I am. Good afternoon, everyone.
Wonderful. Thank you. Please take
Uh,
some time to introduce yourself. And then I know many of your slides have some great resources that you can highlight. And for everyone, you will get the slides, so you'll have all of these included.
Okay, good afternoon, everyone. I am Bridget Hobson. I am a clinical community health worker for one of our medical systems in Ohio. I'm also part of the Ohio chapter of American Academy of Pediatrics. Thank you, Dr. Murphy. A lot of the information you shared in regards to the resources, I'll piggyback on, but speak more to being on the ground within social services and helping these families access the resources and the information. You can advance the slide. So coming from the perspective within a medical setting, food insecurity affects 41 million Americans and is especially prevalent among children and the elderly. Is my picture not, can everybody see me or they just hear me?
I can see you.
Okay,
I can see you.
because I can't see me on the
Yeah,
screen.
we can see you and hear you great.
Okay.
Thanks.
All right, so food insecurity can impact a hospital's bottom line. Hunger can exacerbate medical conditions and drive up hospitals' patient care cost. There are various points of intervention, both clinical and non-clinical, that can shape the hospital's approach to addressing food insecurity in the community. Hospitals are using best practices and innovative interventions to address food insecurities, and I'll give some examples of what I do here in my office. Conducting food insecurity screenings to identify hunger as a health need, develop an accessible and reliable database of social resources, implement an active referral system, provide patients with supportive services such as patient navigators and or community health workers, in some respects one and the same, reduce or remove language and cultural barriers, address social determinants of health that are interconnected with food insecurity such as housing and transportation. So there are a number of local and national resources hospitals can access or share with food insecure community members. And this brief provides information on how hospitals can connect food insecure patients and community members to locate the federal resources. You can advance the slide. Hospitals, again, can play a vital role in connecting patients to resources that address a household's food needs to support patients' health and well-being. There are various points of intervention, both clinical and non-clinical, that can shape a hospital's approach. Most communities have existing resources that a hospital can leverage, or so alleviating hunger is not solely the responsibility of the single facility. Food insecurity screenings. One of the most important steps a hospital can take to assist food insecure individuals is to identify hunger as a need. Many hospitals, like Providence Medical Group that's in Oregon, but also within the state of Ohio, have implemented a screen and intervene strategy that includes screening for food insecurities. For example, I'm going to use my real life example. We have what's called the social determinants. So within a patient's chart, we have what's called the social determinant wheel. And within that, because Dr. Murray made reference to asking the family or the person about their food insecurity. So within this social determinants of health screening that we have within the patient's chart, we're able to go through that chart, that screening, and ask them specific questions about, their health needs, income, transportation, food, and various other resources. And then from that, we are able to put together an assessment and put together for them a plan in order to help connect them to these resources that are out in the community. You can advance the slide, please. So as more and more research emerges on the links between food insecurity and patient health, new interventions are being implemented and evaluated to address food insecurity in clinical and non-clinical settings. Consider these recommendations that best practices when developing a new intervention or seeking to improve existing programs. This develop an accessible and reliable database. That's what I just spoke to. Our social, I call it our social determinants of health wheel, because it's in a form of a circle. It lights up in colors and stuff, which indicates like red being at the highest urgency, green being moderate, and possibly yellow being not so emergent. Can you advance the slide? I want to talk more about helping to help people access the services, because yes, during COVID, it became like a desert out in our community, everything being shut down. And so, yeah, families were, in despair, really, in more despair than they were already in once everything shut down. And so a lot of the community resources, that list that Dr. Murray had up of like the WIC and SNAP and the food bank and other sources like that, all came together, collaborated, banded together to come up with creative ways now to still provide these services to families. And so in a community health worker space, boots on the ground, still in some respects being out in the community to make sure that, either by going and putting information on their door or in calling them to let them know, okay, well, this food pantry, is open, and these are the times. I know that the food pantry here, the Muni lot, they did food distributions for quite a while. And, I actually was down there and they were giving out a plethora of food to like hundreds and hundreds of families that were able to get there. And then some families had, in a way, doubled up to help other families that didn't have the transportation to get to those food distributions. With United Way, the 211, actually, right before I came on here, I was with a patient who is getting ready to lose his employment temporarily because of a medical injury. And so 211 is definitely a resource that, we utilize because they are specific to the person's zip code. So when you call, they'll ask you general information, they'll ask you your zip code, and then they will give you various resources that are in your specific zip code. Can you advance the slide? I know I'm veering off of this a little bit, but again, talking about being able to access the resources. So within our medical practice, we have a system called Unite Us. So in a way, all of these community systems are collaborated together, band together to help get these resources, this information, the education out to the families, to working with the schools. Example, you mentioned about the schools and the food programs and stuff. In my own community, and I live in a suburb in northern Summit County, and the school buses actually came into the housing developments there, on people's streets and stuff, and the school bus from the schools to still give out, nutritious like snacks and milk and, juice and stuff like that to the kids during the pandemic, so that they still could be receiving, those nutritious items. And I just remember seeing all the parents coming outside and the kids in various grades and stuff still receiving that resource. Child food insecurity. What is food insecurity? We already went through that in some of the previous slides, and addressed again, the stress that it puts on the children. I can totally relate personally when Dr. Murray mentioned about, the teenagers and the disruption of school and just the children in general, the disruption of, not being able to go to school and not being on those structured schedules and with meal times and going to bed. And I mean, it was, lack of a better term, it was pretty destructive because there were kids not receiving the services that they were supposed to be receiving if they had special needs. Kids were not getting up. They were sleeping in all day in the bed. If there was nobody there accountable to help them get up. And, even though they had started the virtual learning. So there were a lot of challenges within it, but a lot of it I was able to actually witness within my own and within helping the community, and still, being able to try to bring it together and stabilize it as best as possible. With the senior population, I know we've talked a lot about children. A lot of the programs that were in place before COVID, there were senior, like down in downtown area near Cleveland, the Huff area. There was a really good, vibrant senior program where they would have senior citizens come into the community center and they'd have lunch and plays and trips. They were just doing all that. So amid COVID happening, they still had volunteers and workers that went out into the community and knocked on the door and to still take groceries and resources to the seniors, even in their home, and or collaborating with their apartment building space, and management to make sure that seniors were still, receiving food, calling them, checking on them, just, whatever, finding ways to be creative at all points to still help people be able to access the resources, even though some of the resources may have dwindled, which we know, with shipments not coming in, still being able to, again, work with the Cleveland Food Bank and what they were able to, still have come in, and getting that out and distributing that to families. You can advance. School programs, I just can't say enough about them. I really have to tip my hat to the school programs because, as Dr. Murphy mentioned, they really, came out and were above and beyond, to not only provide nutritional meals for the children in the school when school was in place, but then once they had to make the drastic quick changes to have kids being educated at home, they still found ways to come out and make sure that children had nutritious meals. And parents are very grateful for that. In regards to the WIC program, we have a WIC program located right within the medical facility where we're at. So I work with OB patients on Wednesdays when we have our OB clinic, and if need be, I walk them up to the WIC and, help them, to get signed up for WIC. Also, WIC is in various zip codes and communities. They have certain times, where they can make appointments and they come in and receive the WIC resources and information. I'm sorry, we have like live music here today and they're like playing out in our lobby area. So it's kind of loud. I don't know if anyone can hear it, but you can advance the slide. So again, touched on this already, WIC, the temporary assistance needs, the supplemental nutrition program. The thing about some of these programs like the supplement, like the SNAP and the temporary assistance, those take some time. because they have to apply for those things through Job and Family Services. So, there may be, opportunities often where you have to sit down with a family and or individual and help them, complete the application process, be it online if you're within maybe an office setting, and or you over the phone. Well, I'm going to say it's there, but you're on the phone holding on, waiting for someone to come and answer the call to even start the process. It's very lengthy over the phone. But if the process can be started online, I have a lot of patients that come into our clinic and help them get the application started online. But then still, the wait can be very lengthy, and then once the application is put in, then they may require information. So making sure that, that person is able to comply to, okay, they need to see, housing, proof of housing, proof of income and stuff like that. And making sure, and when I know with our senior population, trying to help them a little bit more in that process, can be difficult, especially if, they're not readily able to access the information. I'm sorry, I've been rambling on. Real quick.
I was just going to say, Bridget, thank you. I want to make sure that we do have enough time for Dr. Levitt. And I know you put some great resources and links in your slides,
Right.
so that everyone will have those and be able to access that. And I know Bridget does have patient care duties that may take her away, but in the meantime, she would be able to answer questions in the chat box if you have those. And I'm sure would be happy to answer any follow-up questions that you may have. So with that, we're just going to move on to Dr. Levitt, and I will let her introduce herself and then get to her slides. Dr. Levitt, just let me know when you would like me to advance your slides.
Okay, so thank you for having me. And I actually started out in primary care 25 years ago, and I've been working in the Healthy Active Living Clinic for the past 10 years. And then when I'm not at the hospital, I love working in my community. I'm a certified personal trainer and youth fitness specialist. So that's what I really love to do when I'm not at the hospital. All right, next slide. I have no disclosures. Next slide. And so the learning objectives, quickly, we're going to go through the benefits of physical activity, the power of play, and physical literacy. And then we'll spend a little more time on incorporating how to incorporate the 5S system to establish routines to help families get more active. And then I'll just give you some practical resources along the way. So we can skip to the next slide. So quickly, we'll just review these benefits. I think everyone's pretty well aware of them. So the physical and medical benefits of physical activity, improving heart and lung capacity, improving strength of our bones and muscles, helping kids develop their motor skills. And then of course the medical, helping control blood sugar, the weight, improving mental health, improving sleep, reducing the risk of heart disease, high blood pressure, diabetes, cancer, help them with coordination and flexibility and balance. And then of course, what's really important right now over the past pandemic is the direct benefit that physical activity has on improving and strengthening the immune system. So I think sometimes parents are not motivated by medical consequences because they're not readily evident in their kids right now, but everyone's pretty in tune to like improving their immune system. So that's one of the tools you can use. And then of course, really focusing in on the more social emotional benefits like improving self-confidence, improving academic performance, and attention and concentration. All right, next slide. And then I think it's really, really important to help parents understand the power of play as a way to be physically active. So it's a really unique opportunity that promotes not only the physical benefits, but also all those social, emotional, and academic benefits. And it helps kids build their brain, build executive function, and it helps them develop those positive emotions, attitudes, and behaviors that are needed in interacting with others. It's also a really, really unique and an ideal opportunity for parents to engage fully with their kids, to tell their kids, I see you, I love you, I'm here with you. And it supports that formation of those safe, stable, nurturing relationships that are so crucial as our kids are growing. It's really particularly important in the presence of childhood adversity. And then we talked about how it improves brain function. So we don't have to view physical activity as being this like chore. If we really focus on the power of play and the benefits that that has on our kids, that sometimes is more well received than talking about exercise. Okay, next slide. So again, this just kind of highlights the power of play and play-based fitness, learning skills, social skills, leadership skills, character development, and then that modulating and buffering adversity that helps downregulate the body's stress system. So that's really important in our kids that are experiencing childhood adversity. And then just the fostering of that curiosity, imagination, joy, those positive character traits, and then just mood boosting and energy boosting potential. Okay, next slide. And then most of you are pretty aware, obviously, that we ourselves and our kids are not as active. We're more sedentary. We're getting less and less active. But these are just some quick stats. I'm not going to go over them for sake of time, but they're kind of startling to see how poorly we're doing as far as getting active. Next slide. So in addition to understanding just the benefits of physical activity, but the power of play is this foundational concept of physical literacy. So physical literacy is defined as the ability, confidence, and desire to be physically active for life. So ability includes developing competence. So competence in those fundamental movement skills, running, jumping, hopping, climbing, throwing, catching. So kids, since they're not as active, they're not confident in these basic movements. And then that leads to a downward spiral of not wanting to be active, right? So if we feel more capable, we feel more confident. And when we feel more confident, we will move more. So this foundation of being physically literate is so important. And that like emerges from infancy. And then as you grow and hit all the developmental milestones, and then it kind of hones in that pre-adolescent, adolescent time where it gets more refined. But a great way to develop physical literacy is play-based fitness. So what that is it's entertaining active play that's strategically structured for age-appropriate movements. And what the result is that lifelong love for being active. So we want to connect physical activity to health and happiness because we want our kids to love being active, not view it as a chore. Okay, next slide. So these are a few resources to help you. If you're seeing families from infancy, just how to develop those physical literacy foundations. And I'm not going to go through them, but you guys will have these slides, but Shape America, there's several of these sites have actual like PDFs with like activities, age appropriate activities with pictures. So you can actually give these to the families. Like, here's some ideas for you to get active with your infant. Here's some idea, because sometimes people really need those practical, tangible, like, what does that mean? What does that mean to be active with my infant? So these will help you. These are tools that will help you. Okay, so just quick, the physical, next slide, sorry. The physical activity guideline, just because I was actually surprised at how the percentage of people that don't know the actual guidelines. So in infants, it's several times a day, at least 30 minutes throughout the day. In 1 to 3 year olds, it's 3 hours. 3 hours of being active of any intensity. Then 3 to 5 year olds, it's at least 3 hours. Basically you can say every 15 minutes while they're awake. And that's where we build into this, like it needs to be moderate to vigorous. And then our school age and adolescents, at least 60 minutes, moderate to vigorous. And then I think it's really important to understand that all movement counts in any increment. So the guidelines were revised in 2018. Prior to that, we were saying it had to be in 10-minute bouts. But now it doesn't matter. Like all movement counts, any increment, because we really want to make these families feel successful. And then we do want some bone and muscle strengthening exercise at least 3 times a week. But again, we're not going to layer this on the families like right away or even define it this way because they won't understand that. So we want to put it into really tangible terms that they can understand. They can understand the power of play. Okay, next page. So the types, we always say, and I think this is where like sometimes clinicians need to be careful. Like they tell families, you need to exercise at least 60 minutes. It needs to be moderate to vigorous. That like what does that mean to a family? So moderate to vigorous means you're feeling a little bit warm, you're starting to have trouble talking in full sentences, having a full conversation, you're getting a little sweaty and you're getting a little short of breath, versus just that easy sauntering like you're walking around the mall. So again, if you're going to like recommend these things to families, we want to make sure we know how to define them for families and put them into practical things that they can do. All right, next slide. Okay, so tips for interaction with families. I think it's really important to remind families that it's so important to dedicate activity time as early as infancy. And as you can see in this picture, they're playing with the baby, just that face-to-face time, that interaction, singing, playing like peekaboo, that kind of stuff. Just kind of let the parents know, like, physical literacy starts as early as infancy. It's so important. Encourage parents to be active role models for their kids, so their kids can just see them being active, and then to get active with their kids. So a lot of times the parents are like, you need to get off the screens and go exercise, but they're sitting there on their screen. So really, really encouraging families to be active role models and get active with their kids. And also, if you frame it too as an opportunity to really bond with your kids, sometimes just reframing it makes them more excited to do it. And then always connecting physical activity to fun. Because again, if it's perceived as a chore or an obligation or work, they're going to resist you. And then that gets back to the physical literacy, because you remember, if you are haven't been very active or you're overweight, moving your body can feel uncomfortable. So when that feels uncomfortable, we don't want to do it. So we want to try to reframe it as something fun we're doing until we get more confident and competent in our movements. Okay, next slide. So setting physical activity goals with families. Again, I like you to reframe using the word exercise or even using the word physical activity to just getting more active, or how can we sit less and move more? Because exercise can just, that word itself can just seem so daunting, especially if you have had a negative experience with exercise and you say, we just need to get you exercise more. That's not going to relate well with the family. Again, sometimes it's like, oh my goodness, I don't have time. How am I going to add one more thing into my schedule? And sometimes, again, it's that the child or the parent doesn't feel confident or competent in moving their body. And so they're not likely to exercise. But if we reframe it as just, how can we get more active? How can we sit less and move more? That seems more doable. So really talking about it in small steps, ways they can incorporate it into their everyday life versus adding something additional on to do. So I like to use what I call the 5S system with families, that helps break things down into smaller goals for them. So each S will actually generate more momentum to help with the other S's and to get more active. So sometimes families, they're not ready to exercise more, but they might be willing to tackle one of these 5 S's. And then if they tackle these 5 S's, that in tune will help them exercise more. So next slide. Okay, so the 5S system, it gives families really practical, actionable strategies. I'm like super big on like tangible, actionable things families can do. Instead of just saying you need to exercise more, make sure you get 60 minutes of moderate to vigorous exercise a day. So let's break this down. So we have structures and schedules. We have sleep, we have screen time, social media, and stress management. And again, these all build on each other. And once you have success with one, it generates momentum or it takes care of some of the other ones. And so they do all affect each other. So I always start with, next slide, structure and schedules first, because for me, this is the #1 tool you can teach families to set their family up to win. We want to set our families up to win, and we want to just set them up to get a series of small wins. So if families cannot manage their time, they're not going to be successful with an exercise plan, right? So I suggest usually starting with a weekly meeting, and I usually say Sunday, but they can choose their day, but Sunday just seems to be the day that's kicking off the week, and it's like a little more quiet for families. So family meeting every Sunday, get out a paper calendar. So no phones at the meeting. We want to teach our kids executive functioning skills, how to plan, how to manage their time, how to set up their schedule, not to how to be on our phone all the time. And I realize a lot of parents use their phone for their calendar, but I actually suggest that they transfer it to a paper calendar for the family meeting with their kids. And again, setting up the structure and having a schedule will help you be able to have success with all the other S's and then ultimately get more active. So setting up a structure and a schedule also help when we add in, so we're adding in, right, healthy lifestyles. Well, that's a lot for families. You need to exercise, you need to eat right, you need to do this, you need to do that. And then they also have their appointments and their jobs and school. So when we start setting up this establishment of that structure and that family meeting, then we can layer in nutrition changes, planning meals, that kind of stuff. So the length of the meeting doesn't matter. Consistency matters. So what I tell families is it helps you with the 3 C's. #1, you're connecting with your kids. You're telling your kids, I love you. You matter to me. You matter to me more than this phone. That you matter to me. They'll think it's an hour and it could be 5 minutes because you're sitting down with them, connecting with them. And then communication. So obviously it's helping you communicate the plan for the week. Like we have appointments, you have soccer, communicating the plan, but also it opens up the opportunity for your kids to communicate with you. They might then start feeling more safe and secure and loved and seen and heard. And so they'll start opening up on things that are bothering them or something they want to work on or that kind of stuff. And then the family meeting creates certainty. So when we have this structured meeting that they can count on every single week, that creates certainty. And in this anxious world of COVID, one thing we really need to create is connection, communication, and certainty. And then as they do the meeting every single week, it gets better and better, easier and easier, it gets more of the flow, and then they can build on that meeting, adding more things in. Okay, next slide. So you start them with that scheduled weekly family meeting, no phones. We have our paper calendars out, and we're going to communicate, appointments, school projects, activities, our meals, if we're eating out, are we eating at home, sports, sleep schedules, etc. And then after they get really good with that structure of that routine, scheduling in that weekly meeting, then I teach them how to do a nightly meeting. I call it the 5-minute miracle, where it's like 5 minutes, like what do we need to plan and prep for tomorrow morning? Get your backpack, what homework, your papers, do you have a project? And then communicating to them what the bedtime is and what the wake up time is. And then what's happening that next morning, like who's taking you to school, who's picking you up, who's, I'm picking you up early because you have an appointment, that kind of stuff. Are we packing? Are we buying? And you get all that done the night before. So the morning goes smoothly and the child is set up for success and has less stress starting out their school day. And this is also a good time once you look to build in, like into that family meeting, you can start building in getting more active. And I usually suggest scheduling in, you can schedule in 3 ways of getting more active. Sometimes families can like wrap their head around this, where you'd say, eventually we want one of each of these every week, but you might start with just one. So the first one would be an organizational or structured activity. So that would be like a sport that they're in, or taekwondo, or martial arts, or dance, or gymnastics. And the benefit of that is you invested in it. So if you pay, you go. So families are more likely, if they're paying for something, they're going to get their kids there, right? So a structural organizational activity, a family activity, which like we're having a family activity that will involve at least one or more family members. And it might be dad's having a day date with the daughter and mom's having a day date with the son, or we're all going to the park, we're all going to the mall. We're setting up a family activity. And then the third one is a me time activity you can schedule in. So we're giving that kid, like they like to do things with their friends. They need some free time, some alone time, some unstructured play. So we're building that into our routines. So once you get that weekly meeting going and you start getting a good rhythm, then you can start building in and adding in these different types of activities, different ways for families to plan their schedule together. Okay, next slide. Okay, so next one is sleep. So sleep, obviously, bedtime routine is important for all ages. Sleep is important for all ages because it helps us with stress, anxiety, academic performance, feeling like we want to exercise. It also regulates our hunger hormones. So sleep is super important. And so it's important, I think, to just start with everything I do. I actually start with awareness, like assessment, like where are you at right now as a family? Where is your child at right now with sleep? And then based on where they're at, what can we take action on? What do you want to work on? So some examples of sleep goals, you can't really see it on this tracker, but this tracker is from the Ohio AAP, Parenting at Mealtime and Playtime. But you can set a sleep goal, like something really simple for families. And again, we want to set our family up to have small wins. So a small win would be like, let's just get the TV and electronics out of the room. They have a tracker, they check it off. Look at that. Like, look how great we're doing. And then it could be no screens 1 hour before bed. It could be having a set bedtime. It could be having a bedtime routine. So we take a bath, we read, we journal, and then we have some tea together, so where you like that could be a goal. So you're giving people like actual tangible goals instead of saying your child needs more sleep, your child needs 10 to 14 hours of sleep. You're giving them an actual tangible practical thing to work on. And the trackers I think really help. I am a paper and pencil person for sure. So I like to give families lots of worksheets like this because it helps them like track off and check off like their success. And then when they see that success, it generates momentum to do more. Okay, next slide. Okay, so screen time. So screen time, we want to address, obviously, because the problem of sitting. We're sitting. But also it messes up our circadian rhythm. The screens, some people have touted a term called electronic screen syndrome, where they're saying the exposure to these screens is mimicking psychological disorders. So it's mimicking ADHD, it's mimicking schizophrenia, it's mimicking anxiety, depression, bipolar, that the kids don't really have deep-seated mental health issues. They have this electronic screen syndrome. So also just some of the games that the kids are playing could be stress-inducing, the violent games, that kind of stuff. So it's important to teach families like, let's figure out where you're at with screens. So they can use the tracker to kind of track I never paid attention, but now that I'm becoming aware of it, wow, I cannot believe how many hours Johnny spends on the screen. But just that couple of weeks of just tracking it, then it makes them aware. Then like, ooh, okay, how can we change this? So teaching families how to communicate screen time boundaries. And again, you'll do the screen time boundaries at that family meeting. So our first screen time boundary is no screens and phones at the meeting. Success, small win, right? And then you can just help them set goals of how they can like, okay, for every 2 hours of screen time, you need to be up for 60 minutes. Or they can set a timer for every 45 minutes sitting, the timer goes off, they have to get up and move. So you can use trackers to help them like kind of have boundaries with their screen time. And then we talked about no screens in the bedroom and no screens 1 hour before bed. That'll also help the screen time. Okay, next slide. Social media. So social media, I think it's so important for families to be aware, and I'm sure they're aware, but I think we need to make them even more aware of the influence that social media is having on our kids. So the influence of social media is more powerful than our influence. And so these resources will really help families set up social media boundaries. So family, like I encourage them to, at one of the family meetings, once they get going with the family meetings, to create like a family media use plan. And the healthychildren.org has a great one. You actually type in the age of your kid, even like a 9-month-old, and it spits out like an actual media use action plan for you. There's a family media toolkit from the AAP. And then the Digital Futures Initiative has some great resources. Lots of proactive parenting plans. It helps you use the power of tech, devices, and social media in a positive way. And it has even things like texting and driving, bullying, like all sorts of resources for families. And they also have a family device agreement or family media plan. So these are great resources to give families. Okay, next slide. And the last S, stress management. So the first 4 S's go a long way with reducing stress. So if we get some of those, just that structure of the family meeting, generating that certainty, that security goes a long way in reducing stress. So when our kids feel secure, they feel less stressed, they feel less anxious. And then also just that less influence of screen and social media will reduce stress. And then just that family connection, the connecting, the communicating at the family meeting reduces stress. So when we reduce stress and have all these other 4 S's in place, we are more likely as families to be more active, and then physical activity reduces stress. So as you can see, they kind of all interact and affect each other. But again, this is where I have you target like 1 S at a time and have the family build success with that, and then just keep building and building and building. And as you're doing those things, they're almost by default going to become more active, or feel like they have more time to become more active and feel more empowered to become more active. Okay, next slide. So the 5 S's, and then like, again, just being aware of resources for family, and it depends on the season. So if you're in Ohio, obviously right now in the winter, we might be relying more on indoor activities and apps and that kind of stuff. So, but being aware of outdoor activities, indoor activities, the apps, YouTube, family fun activities they can do. And then of course the organizational and structural activities. And just even like workout on demand, like resources. And then also like even a good resource is wearing a like wearable fitness trackers, like a Fitbit, because those are really great for families to have like step competitions. Like we're all going to try to get 10,000 steps a day. We can make like a little calendar. So even something simple as like a wearable fitness device will help families get more active. Okay, next slide. I'm just going to briefly go through these. So here's some apps. These are some common ones kids like. The kids love Go Noodle. Healthy Hip Hop's a fun one. Swerk It. Swerk It has a kids version that has music with it. And there's thousands and thousands of apps, guys, but these are just some common ones. Okay, next page. Next slide. YouTube. So YouTube has some great stuff too. Cosmic Kids Yoga is super popular. Box Kids is also super popular. All the dance ones kids love. And then Spider-Fit Kids has PE for your living room. And then he also has a membership called Powerful Playground. And he is really in tune to building physical literacy and the power of play. And so is Recess and Results. Okay, and then next slide. Some outdoor, or just some other ones that parents can Google is the Ohio Climbing and Bouldering gyms, because they can do that inside. playcle.com, that's Play Cleveland. They have some great, actually indoor and outdoor, like especially if families get on their website and on the Facebook page, they're always popping up like fun things to do with kids in our area. You can look up Ninja Warrior gyms. The kids love those. Obviously the trampoline parks, gym memberships, helping families get financial aid through the Y. National Recreation and Park Association has lots of resources. I'm going to go over that next. And then just simple, like we don't have to be fancy. Just take your kid to the mall and walk around the mall. It's free in the winter. And then if it's nice out, obviously parks, they're free. So, okay. Just empowering kids with, or empowering families with basic, we don't have to spend a lot of money. We can do these basic things that are accessible to us. It's a little harder in like, you know, urban areas or areas that don't have safe sidewalks and safe. So we have to get a little more creative with those. But I think tapping into the park and recreation could be a great way to help with that. So next page. I keep saying page, it's a slide. This is a fun little thing you can get from this. It's called ParkRx, parkrx.org. And they have little like posters and little things you can print out. And I think it's just like a attractive printout to like empower families, like use the parks. And they actually have like a prescription pad that you can write a park prescription for the families. So sometimes using the power of a fitness prescription, like I'm prescribing this park activity, it's as powerful as me prescribing you a medication. All right, next slide. And then this is a toolkit from the park program. I love toolkits, but they have some great like free toolkits. I'm not going to go into those, but just you'll get these slides. Okay, next slide. Here's a bunch of websites that also have like a bunch of like on-demand resources, PDFs, ways kids can get active, ways families can get active. Next slide. Again, more websites. There's tons and tons. This is just additional resources if you want more reading or more watching. Dr. Bowling did a great talk, I think it was last year. Or was it 20 or was it 21? I don't know, but he actually had some great resources for wellness in there. And then these are 2 great articles from the Journal of Pediatrics. And then Dr. Murray did a really great talk on the power of play. So you can see those there. All right, next slide. That's it.
All right, thank you so much. And I know we've gone a bit over time. I want to assure everyone that if you do have any follow-up questions, please don't hesitate to email those to me, and I will get in touch with our experts and get those answered for you. Just a reminder, we do have one more webinar coming up in this series, and it's really a deeper dive into our Parenting at Mealtime and Playtime program and all of those resources. And it's really a wonderful program and has a number of resources that Dr. Levitt also highlighted some of those. So please remember to register. I'll include the link in your follow-up email. And thank you so much again for attending today's webinar. And again, please don't hesitate to reach out if you need additional resources or have additional questions. I do see we have one mention. Yes, thank you, Dr. Levitt, for being a fast talker. You got a ton of information in very quickly. So thank you all again. I hope everyone has a wonderful day. And you will be getting a follow-up email, like I said, with the recording, the slides, the link to claim your CME credit, and a lot of additional resources. So thanks again, everyone, and have a great rest of your Wednesday.